Today's topic is kidney transplant, and the presenter is Evelyn Neema Muzungu, a nephrology specialty student in nutrition. Introduction of today's topic is kidney transplant is one option to treat patients with end-stage renal disease. This is done by placing a healthy kidney into your body, where once attached, it can perform all functions that the failing kidney can't. Deciding to undergo the process is a decision between the patient, family, and physicians. Requires careful thought to make sure it is the right decision for you. Up to what point does one need a kidney transplant? When one has end-stage renal disease as a result of repeated urinary tract infections, kidney failure caused by diabetes or high blood pressure, polycystic kidney diseases, or other inherited disorders, glomerulonephritis, which is inflammation of the nephron, hemolytic uremic syndrome, lupus, and other diseases of immune system. Other conditions, such as congenital defects of kidneys, may result in the need of kidney transplant. Selection of a recipient. Appropriate selection is important for a successful outcome. Careful evaluation of medical, immunologic, and psychological status is done to identify and minimize potential complications after transplant. Criteria for transplant. Usually, the recipient is younger than 70 years. Patients have life expectancies of 2 years or more, expected to have improved quality of life. Medical prescription of existing complications has to be done before the transplant. Candidacy is determined by a variety of medical and psychological factors that vary among transplant centers, with diabetes mellitus and cardiovascular diseases considered as high-risk cases. In diabetes patients, preemptive transplant, that is getting transplant before having dialysis or before undergoing dialysis, is always preferred for diabetes mellitus patients. Some centers reject patients with morbid obesity, those who continue to smoke despite smoke cessation intervention being done. Contraindications: disseminated malignancies, refractory cardiac diseases, chronic respiratory failure, extensive vascular diseases, unresolved psychological disorders. Also, some centers some centers always contraindicate when it comes to HIV positive patients. They have contraindications for such cases. Donor sources: compatible blood type deceased donors, blood relatives such as a brother, sister, or father and children. Emotionally related, close or distant living donors such as husband, family friends, distant cousins, and also charitable living donors, known or unknown to the recipient, paired organ donations. Appropriate selection is important for a successful outcome. Careful evaluation of medical, immunologic, and psychological status is done to identify and minimize potential complications after transplant. Evaluation of a donor. On the side of living donor, required to undergo extensive multidisciplinary evaluation to ensure the donor is of good health, doesn't have diseases that predisposes to renal failure, operative complications, psychologically and financially stable, cross-matching done at the same time and again a week before the transplant. Deceased donor must be healthy individuals who suffered irreversible brain damage, must have effective cardiovascular functions, must be supported on a vent to preserve the organs to ensure quality of function, must be free from physical and psychological complications or conditions, permission from the next of kin, even in presence of signs of it's very important. Advantages of a live donor, better patient and graft survival, immediate organ availability, organ immediate organ functions, recipient has opportunity to be in best possible medical condition as the surgery is elective. Pre-transplant procedure, on the donor side, you have to ensure that human leukocyte agents are being checked, urinary tract infection is being done. Also, you have to check urinary tract infections, and you also have to check on cytomegalovirus serology. It has to be done. On the recipient side, you have to check on the UECs, urinary segment, albuminuria, fasting plasma glucose, oral glucose tolerance tests, lipid profile has to be done. LFTs, that is liver function tests, have to be done. Blood group compatibility tests have to be done. Cross match of T and lymphocytes has to be done. Also, renovascular angiography is done. The cost of pre-transplant procedures is between 150,000 to 200,000, by which most Kenyans are unable to raise such money in cash. One disadvantage is that NHIF can be used only during transplant, but not before transplant, not during preparation for the transplant, of which most of the time it is a hard deal for the poor. The donor and recipient see the nephrology for complete history, physical, lab, and radiological studies. Compatibility tests are performed between donor and recipient. Prescriptions for infection is done before the transplant. Psychological support for both the donor and the recipient is offered by a transplant psychologist. Or in some centers, even sometimes social workers can come in if there is no transplant psychologist or a counselor. Hemodialysis is done a day before the transplant procedure. Ensure echogram, lab work, chest X-ray are ordered and done. Ensure the recipient is in optimal condition, especially in matters of nutrition status. It's also very important. Ensure the recipient is in optimal condition, and also ensure dialysis is done prior to operation. The patient on peritoneal dialysis must empty the peritoneal cavity before going for the surgery. Maintain patency of the vascular access of the patient. Label the vascular extremity dialysis. Prepare the patient emotionally and physically for surgery. Review operative procedures and what is expected immediately post-operative recovery. Stress on the chance that the kidney may not function immediately and dialysis may be required for weeks. Stress on the need of immunosuppressive therapy and infection prevention, which is very important post-transplant. Pre-transplant nutrition therapy. Nutrition intervention for patients awaiting kidney transplant is very vital to prevent increased mortality rates at the transplant and post-transplant period due to catabolism, infection, and delayed graft function, etc., etc. Energy intake of between 30 to 35 kilocalories per day is always considered. Protein intake should be between 1.2 to 1.5 grams per kg body weight per day, And most of the time, 50 to 70% should be of high biological value, like eggs, meat, and so on. Sodium intake should be between 2 to 3 grams per day. Potassium intake should be 800 to 1000 milligrams per day. Phosphorus intake should be 800 to 1000 milligrams per day. And vitamin B and C, that is water-soluble vitamins, should be supplemented daily, especially the sources to be from naturally available foods. And also another point to note is that most of the time we have to avoid taking multivitamins because they contain fat-soluble vitamins, which most of the time are stored in the organs. Calcium intake should not exceed 200,000 milligrams per day, preferably with vitamin D3. Transplant team members consist of transplant coordinators, urological surgeons, living kidney donor advocates, when the kidney is harvested from a living donor, that is, financial coordinators, social workers, ethical and legal issues involving transplant, a near relative, spouse, children, grandchildren, parents, grandparents, needs permission of the doctor in charge of the transplant center to donate his or her organ. An unrelated donor needs permission of an authorization committee established by the state of donation to donate his or her organs. Other ethical issues are like safety of the operation of the donor, motivation of the donor, approach to and evaluation of the donor, donation by strangers, the commercialization of donation, surrogate consent for donation, the acceptance of minors as donors. This is a very important ethical issue. Harvesting of the kidney, this is done, or kidneys are removed and preserved up to 72 hours. Most transplant surgeons prefer the transplant kidney before cold ischemic time reaches 24 hours. Prolonged time increases likelihood of the kidney not to function immediately. On the live donor, donor nephrectomy begins 1 to 2 hours before recipient surgery. Laparoscopic donor nephrectomy is done, which is the most common method used, because it is minimally invasive with few risks and shorter recovery time. Decreases hospital stays, pain and blood loss, decreases debilitation and length of work. The second one is donor conventional nephrectomy. Donor placed on literal position and incision made at the level of the 11th rib. The rib may be removed to allow visualization of the kidney. After removal, the kidney is flushed with sterile electrolyte solution and prepared for immediate transplant. The process of the surgery takes 3 to 4 hours. In post-surgical care, the live donor, here we have to maintain renal functions, so we have to monitor them. We have to monitor hemocrotic to access for bleeding. You have to monitor creatinine levels. You have to monitor, you have to administer analgesics for pain. And also the donor is discharged 2 to 5 days and can return to work in 5 to 8 weeks. So that is roughly around 1 to 2 months. Follow up to the clinics within 1 to 2 weeks after discharge is very important, so as to note any changes or any morphological changes, and also other changes which can be noted earlier for correction. We have to acknowledge the precious gift that has been given, that the donor has taken physical, emotional, and financial risk to assist the recipient. Hence, the donor should not be forgotten after the surgery. Donor needs greater support if the donated organ does not work. This is also a point which we have to note. Patient nursed in ICU on the now this is on the recipient side. The patient is nursed in ICU for the first 12 to 24 hours for close monitoring. Priority is maintained of fluid and electrolyte imbalance. Sometimes the patient may experience diuresis in the first phase up to 1 hour. Hence, urine output is replaced 1 millimeter for 1 millimeter of fluid hourly for the first 24 hours, 12 to 24 hours most of the time. Assess for electrolyte imbalances and intervene immediately. Medical therapy, here the goal is to maintain hemostasis until transplanted kidney is functioning well. The survival of transplanted kidneys depends on techniques that suppress immunological reaction. To suppress body's defense mechanism, the patient is put on immunosuppressant therapy. For example, cyclosporin, basiliximab, prednisolone, tacrolimus, those are medications which are used. And also other processes like plasma leukapheresis, lymph drainage are also done. Doses are tapered gradually over weeks, depending on patient's immunological response to transplant. Choice of medication or medical procedures are done depending on evidence-based studies. Renal graft rejection may occur within 24 hours to 72 hours, 3 to 14 days, or more than 3 weeks. Ultrasound is done to detect renal enlargement, and biopsy is done to evaluate the failing renal graft. In severe rejection, or when excessive use of immunosuppressant is required to maintain the kidney, then graft nephrectomy is done and the patient is returned to dialysis. Such cases, sometimes they happen. Risk factors, that is post-transplant. For example, bleeding, infection, blockage of the blood vessels to the new kidney, leakage of urine, or blockage of urine in the urethra. Those are risk factors for transplant. On the infection control, prophylaxis is used against pneumonia, against cytomegalovirus, against tuberculosis, and sometimes also usage of local antifungals against any fungal diseases used. Overall health education, especially on advice on follow-up care after transplantation is done, and also on early detection of rejection, prevention of infection, purpose and side effects of immunosuppressive drugs, adherence to medication, individual instructions on diet and management of intake output charts, resumption of normal life activities is done. So that is about overall health education and how the person will be able to catch up with normal life as time goes by. Post-transplant nutrition care. Nutrition influences allography function in either way, or either positive or negative way, depending on how the patient follows or adheres to nutritional practices. Although most studies are yet to be done on post-transplant nutrition intervention, there is indeed a difference in pre- and post-transplant nutrition guidelines. Suggested micronutrient profile includes protein intake of 1.2 to 2 grams per kg body weight per day, carbohydrates of 40 to 50% of total energy, and fat of more than or equal to 30% of total energy is also required. Some studies suggest protein intake of 1.3 to 1.5 grams per kg body weight immediately post-transplant. And then over time, you reduce it to 1.7 grams per kg body weight per day in women and 0.8 grams per kg body weight per day in men. In key minerals, there is no exact amount that is to be supplemented in diets. And vitamin D has been linked to several post-transplant comorbidities, including polyomavirus, acute rejection, and diabetes. Yet there is evidence of providing a renoprotective effect. Post-transplant patients tend to revert to hypophosphatemia immediately post-transplant due to several factors, including hyperabsorption from bones and secondary parathyroidism. So that is a point of that. Okay, for me, I can say that is a point of debate or a point of further study, so as to know if we can supplement with phosphorus for some time before stopping or not. Low salt diet is also recommended for some time to prevent electrolyte imbalance like hypernatremia or any kind of cases. Multidisciplinary action during resurgery, multidisciplinary action during pre and also post-surgical care. Those people involved are surgeons or urologists, anesthetic doctors, nutritionists or dietitians, nurses, counselors or transplant psychologists, social workers, and etc. But those are the most important people. Follow-up post-surgical. This happens when the patient has recovered well and is discharged. Follow-up is done monthly. On good recovery, patient is seen every 3 months, then once per year. Continue on medication given, for example, is immunosuppressant. Those are the kind of medication which a patient has to continue during the follow-up. And also, you have to monitor one dietary intake. This is a very, very, very important note. Now let's discuss about rejection, because sometimes it happens. Like some cases in Kenyatta, for the past 10 years, at Kenyatta National Hospital, almost 10% of the procedures that are done in kidney transplants, they have come back due to rejection. And sometimes it can be due to not following what they've been told to follow. Or sometimes it can be due to lack of money to buy immunosuppressant drugs. So this is an important also point to note or to discuss. Renal failure persisting after transplant is called delayed graft function, which can lead to the rejection. The graft survival is 15 to 25% lower in those with delayed graft function. When renal biopsy is done and shows features of rejection, IV fluids are started, anti-rejection protocol is started with the anti-rejection team. In case there is no improvement, hemodialysis is started. Types of rejection: hyperacute rejection occurs minutes to hours after transplant, caused by humoral or antibody-mediated B cells production against the transplanted organ. accelerated rejection occurs within 24 hours to 5 days of transplant due to sensitization from prior exposure to one or more of donor antigens. No medical prescription and the transplanted organ is removed. The risk minimized by antibody antigen testing is done. On acute rejection, that is another type of rejection, the third one, this manifests the first 6 months after transplantation is done, mediated by lymphocytes, that is T cells, which have been activated against the donated organs, or development of donor antibodies after transplant results in destruction of the renal tissues, occurs for 90% of the rejections. Chronic rejection is the fourth type of rejection, which occurs from sometimes, okay, I can say from non-reasons. And most risk factors, they include repeated episodes of acute rejections, increased infection, hyperglycemia, hypertension, hyperlipidemia. A point of notice is that in adolescents, people, renal transplant recipients, most of the time they have poor outcome. This is because of non-adherence of most. This is because of non-adherence, and this can lead to graft rejection. Thus, more impacted than the rest of age groups, and also they lack support system. Other possible interventions are motivational interviews, patient education, and monitoring, which has to be done extensively. Now, the way forward to go so as to help such situations, you have to increase awareness of kidney disease and the impact it has in the society, and what to do or where to seek help in case you need transplant. And also to develop a well-coordinated transplant program that is multidisciplinary, like the team which I just mentioned, which comprises of surgeons, neurologists, nutritionists, nurses, and so forth. To reduce a cost of drugs and workups for the patient, which is highly costly. I can say it's really, really expensive, very expensive. And also the legislation to allow for cadaveric transplants. Thank you so much for listening. Is there any questions or addition? Hello? Any additions? Or any questions about today's topic? Any comments or additions? Thank you so much for listening. Thank you so much for listening. And can Milan help us? I'm done with today's presentation.
Thank you, Neema. That was a good presentation. Um, I don't know if anyone has something to say. Let me see.
What do you, for me, I have a question. What do you think about the legislation to allow cadaveric patients or cadaveric transplant for those donors who are brain dead, and then you have to harvest an organ so as to help a living donor? I mean, so as to help a living recipient. What do you think about that legislation, or about the reduction of costs for the drugs, both pre-transplant and post-transplant?
Um, Neema, would you come again with your question?
My question is, what do you think about the legislation to allow for cadaveric for the cadaveric donors, or those donors who are brain dead?
Um, I think the practice is there,
Mhm.
and maybe in Kenya it's not so common, but I understand in the Western countries it is there. You donate your organs before you're dead. I think in our country it can but again culture, eh? People might say you're preempting your death, but it can. I think it can. Maybe I add something on transplants and nutrition.
Yes,
Am I audible, Nema?
you're very audible. Am I audible?
Okay. Yeah, though you're faint kidogo, but it's
Oh,
okay. So, yeah, I wanted to add something on nutrition care, because for transplants, you
yes,
understand that as
mhm,
nutritionists, we also need to prepare our patients for transplant before,
yes,
post transplant, during transplant, and after.
and after,
Pre,
yes.
yes, and post.
Quick input,
And
yes.
yeah, so that you because renal transplant or kidney transplant is a very sensitive um, procedure, and since the patients are taking a lot of immunosuppressants, then the level of hygiene should be high.
Thank you so much for pointing out that.
Yeah, so you must handle food preparation, food storage, and also when the patients how are they supposed to eat. You talk of raw foods, their preparation, so that they don't get these infections, because infection, you find most of the rejections, they come in because of
Infection.
the infections, yes, whether bacterial or viral. So it is important, as a nutritionist, to prepare these patients so that they know what they are going to meet. As much as the doctors should do their part, the nurses should do their part, and as nutritionists, we also need to do our part, okay, so that we don't find increased rates of rejection due to negligence. Yeah, thank you so
Thank
much.
you. Thank you so much, Priscilla. Any addition or question from my fellow panelists? Can we invite Mr. Milan to help us wind up today's presentation on my side? Because today we have two presentations, so we have to welcome the other person. Anyone who can find Mr. Milan to help us?
Penina. Aya, nawaingiza.
Penina, Damaris, Effie, welcome all of you. Any questions or addition?
Yes, Penina.
Hello?
Yes.
Do I just start?
Um, you've not opened your camera. Um, thank you, Neema.
Thank you,
Very good.
Yeah. So,
Akatabira amazi.
Penina, how are you?
I'm fine.
Okay, you can start.
Good evening. Am I clear? Can you hear me?
Very audible, Penny.
Ndamwira sienda nigusienda gwa.
Can you hear me?
Yes, we can hear you.
Susan? Susan,
Eh, Yes, hear you.
mute your mic, please.
I'm already mute.
Okay, so you're hearing me. I hope I'm clear. I'm Penina Wangoi, a nutritionist in Kiambu County, currently working at Tigoni Sub-County Hospital. And this evening, I'm honored to present to you a topic of renal pharmacology, of rather pharmacology in renal systems. We'll be looking at the background, then we try to understand what the nephron is, the functions of the kidney, then we look at the diuretics and their sites of action, we look at the RAS system, and then we will conclude. Mhm. Kidney function is measured by GFR, which is the glomerular filtration rate. Kidney function is with a GFR of 60 and higher is in the normal range, while a GFR of less than 60 may be an indication of a problem with the kidneys. Whereas a GFR of 15 and lower may be an indication of kidney failure. For someone who has been confirmed by the doctor to be having CKD, it is important to take steps so as to protect their kidneys and slow disease progression. Ways to once you've been confirmed that you have kidney disease, there are several ways where you can manage the disease. You need to control your blood pressure, monitor blood glucose levels in case of diabetes. It is also important to work with the healthcare team to monitor the health of the kidney. It is also important to take medications as prescribed, work with a dietitian to develop a meal suitable for CKD, and if someone is smoking, it is wise for them to stop. We need to understand the functions of the kidney. One of them is balance of electrolytes, plasma volume, and acid base. It is also the one that activates vitamin D. It synthesizes erythropoietin. It is also the one that does the excretion of urea, uric acid, and creatinine. Then, for us to understand how the kidney works, it is important for us to first of all understand the RAS system, which is a complex multi-organ endocrine system involved in the regulation of blood pressure. It does so by balancing fluids and electrolyte levels, as well as regulating vascular resistance and tone. Pressure. RAS system is activated when there's a drop of blood volume so as to be able to increase water and electrolyte absorption. We continue the RAS system when it is activated. When there's a drop in the blood pressure, juxtaglomerular cells are activated, which leads to prorenin being cleaved into its active form, which is renin. which is then secreted into the bloodstream. Renin then acts on angiotensin, which is produced by the liver to form angiotensin 1, which is in an active form. The angiotensin converting enzyme ACE, which is produced mainly in the lungs, further cleaves to angiotensin 1 to form angiotensin 2, which is the primary active peptide of RAS. Angiotensin 2 is a potent vasoconstrictor, which leads to increased BP. In instances of high BP, the atrial natriuretic peptide ANP, which is secreted by the cardiac basal cells, is able to reduce the blood volume by leading to a reduction in blood pressure. In instances of low BP, angiotensin 2 also acts on the brain, where it is able to bind the hypothalamus, which stimulates thus increasing water intake and eventually raising the blood volume. By acting on the pituitary gland, angiotensin 2 also stimulates the secretion of vasopressin, also known as the antidiuretic hormone ADH, which increases water retention in the kidneys by adding water channels, which are also called aquaporins, to the collecting ducts. Angiotensin 2 stimulates the secretion of aldosterone, which is produced by the zona glomerulosa of the adrenal cortex, found in the kidney. The retention of sodium in the kidney leads to increased blood volume, thus BP. I have a diagram that's explaining the RAS system. We continue. So we've explained how the RAS system works, but there are certain conditions that would interfere with the function of the RAS system. Those conditions include the chronic hypertension, kidney and cardiac failure. The high BP as a result of chronic hypertension needs to be counterbalanced by the use of medication. So now we go to hypertension. We've seen what the RAS system is and what it does. Hypertension is a medical condition characterized by a persistent elevation in the arterial pressure. In hypertension, systolic BP values are more than 130 milligrams per mercury, while the diastolic reads more than 80. We have two types of hypertension: primary hypertension, which in other books you'll find it's been written essential, which is an abnormal high BP. It is not a result of any medical condition. It could be multifactorial. It could be due to obesity, family history, or eating unhealthy diet. And it is reversible if one changes their lifestyle, or maybe if someone is obese, they lose weight, they start eating healthy, it is reversible. Then you have the secondary, which is caused by another condition or disease. It could be due to kidney disease or thyroid problems. So when someone has hypertension, they have to use antihypertensives. And now we go to the class of antihypertensive. We start with the angiotensin receptor blockers. ACE inhibitors, they work by preventing the conversion of angiotensin 1 to angiotensin 2, thus keeping angiotensin in its inactive form. Remember we said the angiotensin 1 is in its inactive form. Because angiotensin 2 is a vasoconstrictor, when its conversion is stopped, there's vasodilation which leads to a reduction in the systemic BP level. An example of an ACE is enalapril. The pril class are called ACEs. Then the next one is angiotensin receptor blockers, the ARBs. Their mode of action is by preventing the already converted angiotensin 2 to act on its receptors, thus exerting similar effects as the ACE inhibitors. When the process is stopped, the blood vessels dilate so that the blood can flow easily. An example of an ARB is losartan. You also have other classes of antihypertensives. You have the alpha blockers, which act by blocking the alpha adrenergic receptors, which in turn relaxes, thus dilating the blood vessels. This reduces the BP against which the heart has to pump, thus reducing the BP. I hope you're all in class. Someone to tell us an example of an alpha blocker as we continue. Then you have the beta blockers, which work by blocking the beta blockers of the heart, thus allowing the force by which the heart is using to pump the blood, and in return, the heart rate is lowered. A beta blocker, an example is atenolol. Then you have the calcium channel blockers, which work by blocking the flow of calcium into the muscles, and this causes the muscles to relax, thus dilating. This reduces the pressure against which the heart has to pump, and in turn the BP. An example is amlodipine and nifedipine, and all the pins, I believe. Then we go to another function of the kidney, which is vitamin D synthesis. It plays an integral role in calcium and phosphorus metabolism. Vitamin D is converted from calcidiol to calcitrol in the kidney. CKD progression impairs the conversion of vitamin D into its active form, and these complications can progress to renal bone disease. A drug that can be given to counter that can be cholecalciferol. It is also the duty of the kidney to synthesize EPO, erythropoietin hormone, which is responsible for production of RBCs, which themselves deliver oxygen to all body tissues. Progression of CKD impairs its production and can eventually lead to anemia. There is no other way of getting EPO. The kidney cannot synthesize, so it has to be given. Then we come to the nephrons. We should remember that the nephron is the structural unit of the kidney. It's duty to transporting ions along the nephrons, and it is important for the absorption of sodium and water, maintenance of plasma volume, PP, and urine production. Now we had antihypertensives, and now we have diuretics, which act on the nephron. And diuretics are indicated for treating edema, congestive heart failure, hypertension, renal disease, liver disease, glaucoma. I also have a diagram here of how the nephron is structured and what happens where. So we have different classes of diuretics, and which work at different sites in the nephron. We could start with carbonic anhydrase inhibitors, which act on site 1, which is the PCT, the proximal consolidated tubule. Anhydrate in the PCT generates bicarbonate and hydrogen to form water and hydrogen. The inhibitor stops the process, that causing a sodium bicarbonate diuresis. A drug in the class of carbonic anhydrase inhibitors could be acetazolamide. Then the next one is osmotic diuretics, which are inside two. They are in the PCT. They work by increasing the tubular fluid osmolarity, thus pulling water into the collecting tubules and preventing water reabsorption, which results in osmotic diuresis. In other words, they inhibit paracellular reabsorption of water and sodium chloride in the proximal tubules by reducing the osmotic drive force. An example of an osmotic diuretic is the mannitol. Then we have the loop diuretics, which are on side 3. They act on the loop of Henle. The thin descending loop of Henle is permeable to water. This is mainly due to the presence of aquaporin 1 channels. The reabsorption, it is the primary site of sodium reabsorption. The thick ascending is impermeable reabsorption. The driver is sodium potassium ATPase. It actively pumps 3 sodium ions out of the cell and 2 potassium ions into the cells. Loop diuretics work by inhibiting sodium potassium cotransporter in the thick ascending loop, thus stopping sodium potassium and chloride reabsorption. In return, this affects the concentration, thus decreasing water reabsorption in the DCT and collecting duct. End result is increased excretion of sodium in urine and significant diuresis. An example of a loop diuretic is a furosemide. Then we have the thiazide diuretics, which are in site 4, which is the distal convoluted tubule. They exert the diuretic effect via blockage of the sodium chloride channel in the DCT. When the sodium chloride channel is blocked, decreased levels of sodium are reabsorbed, resulting in excretion of the said sodium and water. Drug is the HCTZ or the hydrochlorothiazide. Then we have the potassium-sparing diuretics, which are in site 5. They act by inhibiting sodium reabsorption in the collecting tubule by either binding sodium chloride, or which is the epithelial sodium channel blocking agents. An example being the amiloride, or by inhibiting aldosterone receptors, e.g. being spironolactone. This prevents excessive expression of potassium in urine and decreased water retention. This is just a chart of showing the sites. I have a chart showing the sites in the nephron. Then we have all these diuretics. They have various side effects. Let me maximize. Like the carbonic anhydrase inhibitors, we've said their site of action and their adverse effects is metabolic acidosis. They can cause metabolic acidosis. We have the osmotic diuretics. And the adverse effect is shifting of fluid from intracellular to extracellular, and it also
Hello, Penina. I can't see you on the screen. Is everything okay? Hello, Mr. Milan. Can you come in and help us? Hello? Thank you, Penina, for the good presentation. Priscilla, Mr. Milan, Effie, we need your contribution here. Then we need Mr. Milan to come and help us in. Can someone contact Mr. Milan? Welcome, Penina.
Thank you, Penina, for your presentation. Thank you, viewers, for listening. I think it's a wonderful presentation. Let us discuss again tomorrow. Thank you. Bye.
Thank you.